during my training, I had an opportunity to spend some time in both Cape Town, South Africa, as well as a town outside of Cape Town, Worcester, South Africa. And really at the time, what it had become very exciting is that they'd sequenced the whole genome of MTB not long before, and started to really recognize what were some of the mutations that highly predict drug resistance, particularly to the first line drugs, isoniazid and rifampicin or rifampin. So I was there really to start looking at, okay, how much could we start considering this as a clinical predictor of response? So we were looking at different mutations in isoniazid and from clinical charts in sort of a retrospective cohort. But what became clear and exciting is that as the sequencing became a standard part of diagnostics, there was almost like this new opportunity to say, since they have centralized labs in South Africa, but in many high burden settings, you could use that laboratory information to start to really tease out where in the country you're getting a higher burden of this harder to treat form of tuberculosis. And so instead of so that's where a lot of this came from, was could we start to use this routinely collected laboratory data to both start to better understand what's the differential? Are all communities equally impacted? Do we see certain communities more impacted by drug-resistant TB? And starting to think what could then be drivers of that as well. So I think our basic outcomes really got summarized in our paper in PLOS Medicine in 2013.
Okay.
And in that paper, what we really said was that there is an opportunity here to use this type of routinely collected data for more surveillance. So we felt that using one of the province's data, the Western Cape province, which albeit was maybe better organized and collated than some of other parts, that there really is an opportunity. That what we found was that there both is spatial heterogeneity, so different communities are differentially impacted, even after adjusting for TB burden. So it's not like every community that has a lot of TB also has a lot of MDR TB, and that this change fluctuated over a 5-year window, so that you could almost start to say, you could use this as a bellwether to say how well are interventions helping. I think those were some of the biggest takeaways, is how do you organize this type of data, and that there is enough variation that you could start to imagine targeting. From this project with other collaborators, we've gotten further funding and are now working with national data with colleagues at Wits University in Johannesburg, trying to look at, again, some of these patterns, and others have done it as well. But again, at the time, it did feel like a breakthrough to say, how could you organize this kind of data into something that could start to be a metric, like a surveillance metric. I mean, I think we all now are used to seeing this with COVID, but at the time it's, you know, not all infectious diseases yet were really using this kind of routinely collected data for that. I think we all realize that tuberculosis, although an ancient disease, is one that's really been understudied and underfunded in many ways. It's not an easy pathogen because of its long time from infection to disease, and then hard to treat disease. These are not easy cases to study in cohorts. But I think it continues to be, now there's more deaths from COVID, but after that, it continues to be like the leading killer globally. And so what's been really compelling for me, and what I really appreciated about Fogarty, is that the colleagues that I work with in South Africa have just opened doors to understanding and advancing the science. And so the partnership, the international partnership, has been incredibly rewarding, and I've learned a tremendous amount from my mentors and colleagues there. this has gone in multiple directions. One is, as we said, continuing to try to improve how do we, when we have these databases full of information about routinely collected data, how can we start to translate that into better understanding of disease spread and evolution of disease. And also what's been really interesting in the last 10 years is that the diagnostics keep getting better. So expert MTV RIF came on, there's then expert ultra replaced it. There's even now, there's the Hain extended release, or the SL, which gets us second line drugs. All of this means that when you're getting the routine data, there's more and more rich opportunity to understand. And I think we're even trying to think further, if we can get sequencing information, how does that impact surveillance? I think the other piece of this was that I came to really appreciate, again, what are some of these other cofactors when it comes to TB disease, and that we, you know, HIV is one that we all talk about, but that there's these other comorbidities or cofactors that are really important. And working where I was in the Western Cape, there's a high burden of alcohol and other substance use. And so that is then the other piece that this has really launched me into, is better understanding, again, another area that's traditionally been thought of as hard to study, but I think is actually really important group of people to include in research and include as modifiers. So we've gotten 2 follow-on R01s in this area, actually 3 now, where we're trying to understand how alcohol impacts on tuberculosis treatment response. And that's not just in drug-resistant TB, that's also drug-susceptible. And then also, how does TB spread amongst persons who smoke illicit drugs? And I guess, again, it comes from that original K concept of how do we start to understand who are the most impacted populations and really target them for support. Both to understand, I mean, there's an importance to understand the biology, but there's also the importance to say, what else can we do to actually do implementation science around this? South Africa is critical in the sense that it has some of the highest burden of TB in the world. So although a small percentage of their cases, only about 5% have RIF resistance and 10% have isoniazid resistance, because you have so many, just sheer number of cases, you end up with just a huge number of people impacted by this. And the reason that's, again, important is that our first line drugs are no longer effective. And so you have to start going to what's traditionally been harder to treat regimens, although WHO just came out with what may be finally a breakthrough to treat. So there are other parts of the world. So your question of who gets it and why, I think that's been another critical breakthrough in the last decade, is that there'd originally been this hope that it was, most people were still infected with drug-susceptible TB, and that they would then acquire resistance. But we've come to see in South Africa, which is a more mature outbreak, I guess you could say, or epidemic, that most of the resistant TB is actually transmitted. And so it does get to this idea that certain communities, the strains that are circulating, have a higher likelihood of being already having RIF resistance. So it still may be the minority, it still may be only 10 or 15% of the cases, but that still means that people will catch it in that form. And so what it means is that we need to better understand where it is so that we get people on the right drugs faster, because that's what's going to break the chain of continuing to transmit it. And I think that there still is a lot of questions about why certain communities, the rifampicin resistance becomes so successful. So colleagues in South Africa, such as Helen Cox, who's at University of Cape Town, has interesting theories and some interesting data, as well as my mentoring colleague, Rob Warren, to say that people with HIV may be particularly good incubators for RIF resistance evolution, and then you get a fit strain that transmits well in the community. But we would say that we don't really, I don't think anyone knows truly what is the social context that, I mean, we know the social context that allows TB to spread. It's overcrowding, it's malnutrition, it's poverty, it's certainly we see it more in incarcerated settings, but I think why specifically for RIF-resistant TB, we're not completely there yet. So I think that we need continued attention on tuberculosis. So I think that a lot of us are holding our breath to see what happens now after COVID to tuberculosis. There's certain things that may be beneficial if there's less stigma around wearing masks in public that can help a respiratory pathogen from being spread less. But there was a huge decline in cases detected globally, including in South Africa in the last 2 years, as people stopped going to clinics and people were scared to sort of go and get the care, and also care was redirected. So it was sometimes harder to access care. And so I think we are holding our breath that is, as high as the numbers are, that there may be a resurgence now again in the next few years. I think continued attention is probably the biggest thing. So, and that's both clinical resources, that's research resources. You know, there's a lot of discussion again about what our newfound understanding around vaccines means for the TB field. And I think there is a lot of real excitement now that we have some new, for the first time in decades, we really do have medications that are coming out, including for drug-resistant TB, that are going to be easier to tolerate. So instead of being injectables, they're all oral regimens. They can be mostly delivered in an outpatient setting, which for most patients makes it much easier to engage than having to be hospitalized for months at a time, which has been traditionally the model, at least in South Africa and many parts of the world. And the side effects are not that bad. But to avoid additional resistance emergence, we need to continue to fund and support the ongoing sequencing and detection of cases, so that if we do start to see, like one of our new drugs, bedaquiline, we definitely have started to see some resistance emergence. And the question becomes, where is it occurring, under what circumstances, and what can we do in terms of adding other drugs to the regimen or early diagnosis of the resistance to avoid it becoming, as we said, a more stable and easily transmissible form of the organism. And so I think the work that we continue to do with a lot of colleagues is to better understand where is transmission occurring. And then, like we said, I think this ongoing regular surveillance with as quick a turnaround as we can get is really important, especially as we roll out these new really exciting drugs, so we don't blow through them. Not that, I mean, so far it doesn't look like we are, but that's what we're trying to avoid. Again, I think that the Fogarty is wonderfully unique in terms of really recognizing the importance of this type of international work, that drug-resistant TB, we're not really able to study it in our domestic setting, and yet it's critically important for us here as well. I certainly in my clinic here see cases. I just don't see enough that I can do this type of work here. And so I think that is something that as an institute, I really appreciate is that it sometimes takes on topics that people might at first glance say is only an international focus, but I think is really important for us globally and for the global sort of population. And like I said, I also just want to make sure that it's clear that I just learned so much from the mentorship that I received in South Africa. And that was, again, something facilitated by this support in Friends of Fogarty.